Okay, so for the third task, which my phone was being a little screwy, so the third task we're going to just discuss how everything kind of plays together, the stages of anesthesia and the physiological and the reflexes. And the biggest part of it is that you really need to make sure that we're not just looking at the ECG machine or the monitoring devices, that we're actually using our, look, listen, feel. We want to be listening to the heart. We want to be actually looking at the chest, watching the respirations, gauging, checking the mucous membranes, resetting, the SpO2 monitor, making sure that it is functioning properly. Those are some of the bigger things that it's the most important to do, on top of anything else, to just so we have a real grasp of how our patient is doing. I'm sure our EKG could be doing one thing, but in all actuality, I could have a heart rate of 50 and not know it. So when looking at everything put together, we want to make sure that the heart rate and the blood pressure are all working together. I know that when I have a really high heart rate, I'm most generally going to have also a really low blood pressure, and the reason for this is that the heart is having to pump a little bit faster just to make sure that all the tissues are getting the perfusion that they need. And then also as things start normalizing, so if I do a bolus of fluids or I give a little bit of head of starch, I'm going to start seeing that blood pressure start coming up. I'm going to see the heart rate start coming down. Everything's going to start normalizing, which is what the body wants it to do. And then once everything starts normalizing, other things will go back into place. So I'll start having better perfusion. My patient will probably start pulse oxing better. Everything will start working together. Probably a lot easier to keep them under anesthesia at that point. Things work in reverse as well. So if I have a patient that has a really high blood pressure, I'm generally going to have a really low heart rate. And the reason for that being is there's some vasoconstriction going on. That can be seen in drugs like dexdomitor. And that's not all the time too. It's just more of a generalized thing that, the higher your blood pressure, the lower your heart rate, and then vice versa. So that's something to take into account. Another good physiological thing to look at is our temperature. We want to make sure that we're not becoming too hypothermic. So anytime a patient drops below 98, I start to get a little bit worried, start taking extra precautions. I actually start taking extra precautions once their temperature drops below 100. I want to make sure that I'm staying on top of it because they can lose body heat very quickly, especially under anesthesia. So once they start losing their temperature, once their temperature drops below 98, then we're going to start seeing problems like hypotension. You're going to have to start probably seeing a higher heart rate. Perfusion isn't going to be that great, which means oxygen really isn't getting to those vital organs like I need it to be. The brain, we could have some issues. Tissue perfusion is the biggest thing, especially when it comes to anesthesia. I want to make sure that the blood is making it around, having good oxygenation to it. Also, it can be harder for us to keep our patients under anesthesia. So I might need more anesthesia. I might need more anesthetic gas if my patient is hypothermic. And then that's going to make it harder to keep the blood pressure up, which is going to keep it harder to keep the heart rate normal. So as you can see, everything kind of plays together. So when my patients start having the lower blood pressures, we're going to also start seeing, I'm going to probably be in lower stages in my anesthetic planes as well. So if I have patients that are hypothermic, they might get too deep, they might become too light. Just all those things kind of play together. So definitely look at that as well. So I think that is it. Thanks.